Thank you so much. I hope I'm audible.
Yes.
Yes, ma'am.
Okay. Yeah, thank you. And so sorry for the delay. There was some technical issue. My Zoom was not working properly, which is why I got a little delayed in joining. Sangeet, can you share the PPT? Yeah, thank you. Thank you. Okay, so before we jump into the nitty-gritties of communication, let's first think about why we are talking about communication in the first place. Why do you all think it is important? Please share. It's a very open forum. Let's all talk.
Either type in the chat or speak. Either way is okay.
So when you think of palliative care or when you think of the medical profession in general, why do you think communication is important? Okay, I can see some responses in the chat. Okay, yeah, quite right, all of you. I also want to ask you to share something personal today. Think about yourselves when you were not a doctor yet, okay? Maybe when you were a kid or when you were in college or something. And I want you to share one good memory of meeting a healthcare professional and one bad memory of meeting a healthcare professional. Anyone who would want to share? Something that has stayed with you. Anyone?
Yeah. So my father was so and interacting. And one good memory I still think about was grade 6. Was having the new school.
Ma'am, I
So,
think your audio is audible. Can you do it more clearly?
Oh, it's not.
It's breaking a lot. It's
Okay,
breaking a lot. Maybe.
Yeah, it's. I think my Wi-Fi is not really picking up today. That's okay, ma'am.
No, now we could hear you better. That's all.
Oh.
To initially, so try like come close to the mic and.
Yeah. So I met with this psychiatrist. I was my father's friend, and it was the way he spoke to me, like in a non-threatening way. At that time, I don't know what kind of specialty he's dealing with, but I felt after that I stopped having my frequent wheezing attack after that, because he made me understand it is not actually my wheezing attack. I'm just hyperventilating because it is a new school, new circumstances, new friends, and a new sibling at the house, and everything has made me feel that way. And after that, I was fine. One bad memory is with my dentist. First extraction, good teeth for orthodontic purpose, and no communication. What he's going to do, nothing. And I went in for a first intraoral section, and till now I'm a dentist. I can't sit in the dental chair without having a palpitations.
Okay, okay. Thank you. Thank you so much for sharing that. Yeah, so see, basically, what she just shared, and also what would have come in all of your minds about your own good memories and bad memories. Generally, good memories would be with doctors who looked at us as fellow human beings, who spoke with us with genuine care and concern and respect, right? Someone who did not treat us from a high chair, looking down upon us, right? So that would be a good memory for us. And communication is definitely a very big part of that. And so that is also why we're talking about communication today. And it's not just about being in a patient's good books, right? It's also about treatment adherence. It is about the patient's need and right to know, as somebody has already mentioned in the chat, about their condition, to have clarity about treatment options, about prognosis, about the professional being accessible to openly asking doubts and clarifying whatever is misunderstood or not understood in the first place, right? Next slide, please. Yeah. Also, studies, research shows that there is a major unmet need for communication about the disease, the prognosis, the treatment options, side effects, and everything related to that, right? So what does that tell us? Next slide, Sangeet. It basically tells us that we avoid difficult conversations. And maybe because there could be multiple reasons to it. Maybe because we don't know how to do it. Maybe because we don't feel skilled enough. Maybe we feel uncomfortable doing it. But we need to put in efforts and start doing it, because good clinical communication gives us a lot. Okay, it enables the patients to express their needs very easily, efficiently. It helps them clarify doubts and any baseless assumptions that they might have. It not only helps the patient, it also helps us, okay? Because it helps us to better understand the patient's condition. How is that condition? Like, how are the symptoms changing? How is that change impacting the patient's quality of life? Simply put, we start seeing very clearly exactly where the patient stands physically, mentally, emotionally, and spiritually also. Right? So it brings clarity to the clinical condition, and this can help us better understand the patient's thought process, the meaning that the patient attaches to his or her situation. And through good communication, the physician can then convey the required information about the disease or the plan of care to the patient in a manner which helps them feel supported, because we already know how the patient is feeling about their condition. Right. Secondly, it also helps build rapport, which again aids in treatment adherence. Rapport will help the patients and families deal better with the emotional responses also. And they're definitely going to have strong, intense emotional responses to the kind of illnesses and the uncertainty that we see in palliative care. Next is, we all know that long-term clinical relationships are sustained on trust, right? And communication helps build trust. Uh, so you might have already heard this quite a lot, that in palliative care, the patient, the family, members of the treating team are all going to be equal participants in the treatment process. And when there is mutual trust among members of this team, it will encourage rational, shared decisions about the treatment. And then the patient is more likely to actually complete the prescribed therapeutic plan and to adopt health promoting behaviors, which is what we all want, right? And lastly, of course, as I already mentioned, better decision making. So it allows a balanced decision to evolve, where we are considering the patient's values, the patient's priorities, their belief systems. And at the same time, the decision is also supported by clinical judgment, clinical evidence, and rationale. So it's not we taking the decision for them. It's not unilateral. Now, next slide, please. Yeah. Okay, so I would like to tell you about a patient of mine here. I have been telling this patient's story in all the communication sessions that I have conducted so far, mainly because the crux of this case has always been communication. So let me tell you about S. She's a 37-year-old lady living in a nuclear family. She's educated up to 10th standard. She, her husband, and her 11-year-old son, they live on a farm where her husband works as a caretaker of that farm. And this patient, she's unable to understand English. She follows Hindi, but not very fluent at it. She understands, she's very fluent in Konkani, which is her mother tongue. So, and given their socioeconomic condition, the lack of literacy, lack of exposure to cities, etc., the husband and her, both of them are quite hesitant when it comes to big institutions, big hospitals, where they feel they won't be entertained. Or, for example, her husband feels that he'll ask obvious questions and end up looking like a fool, or he won't understand what the doctor is telling him anyways. So, and they've never had to go to such a place either until now. Both of them were quite fit, young, and whatever little health issues they've had so far, minor ones, they've managed with the primary health center in their village itself. And now, out of the blue, this lady was diagnosed with a shocking case of kidney failure, and the reason being unclear. When she went to the PHC with complaints of tiredness, swelling of feet, they just urgently sent her to the big government hospital in the capital city, which is around 3 hours from their place. And basically, the doctors at the PHC did not want to deal with the communication. And they didn't want to deliver the news or the possibility of it also. So they kept mum, but they asked them to rush and do these tests urgently. And so when that happened, the owner of the farm, who had employed her husband, he took matters in his own hands and he took them to a private hospital and he accompanied them to a specialist there who did not speak the regional language. Okay, the specialist was from outside of state, so he did not know Konkani. Whatever he spoke was either in English or in Hindi, and directed at the patient's boss because he would understand, right? And the husband, who was already intimidated by the setup and the doctor and the reports, started pushing the boss ahead whenever it was time for discussions with the doctor, assuming that if he goes all by himself, he might either misunderstand or panic. The patient was not told anything about the diagnosis except that her kidney was not functioning properly. That was the only thing she knew. Her treatment began, but there were no results. And when they went to the doctor with the reports, he just turned to the couple and said curtly that they should get her parents next time because they'll have to donate her a kidney. And the patient found this to be very rude, very insensitive. And she refused to visit him again. She was like, I'm not going there again. And then she was taken to a different doctor who would also not communicate to her directly, but at least he was not rude. So for her, that was still okay. Now, the husband, and on the home front, the husband with his prime defense mechanism of avoidance, he got her everything. He got her medicines, good food, fruits, whatever, everything that was required. But he never spoke to her about her illness. They just avoided the topic altogether at home. And the only time that he spoke about her illness was when he got angry at her that she wasn't taking her medicines properly. He also complained about this to his boss, the owner of the farm, who contacted me for a consultation because she was not taking her medications. Right? That was how I came into this entire picture. And let's just stop here for a while. And based on what we know of S, do we all agree that what was happening until now was poor communication? And if we all feel that that was poor communication, why do you think so? What about the entire thing makes you feel like, oh, this was poor communication or that was poor communication? Anything? Anyone, you can type in the chats or You can unmute.
Sangeet, can you mute someone's voice is causing some interference, no? So can you please look into that, Sangeet?
Okay, ma'am.
Assumption that she would not understand. Yeah, definitely poor communication. Can you point out where you saw that poor communication? Anyone? She was not knowing her diagnosis. Yes, definitely. Language barrier should have been addressed. Course of management not explained. Possibilities not explained. Absolutely. She was not explained about her condition. Yes.
Maybe they should have just spoken to her. What do you know about the illness? At times we realize what they have understood and then we can explain. Once they realize, it becomes a bit easy for us also. It might be
Right.
difficult in the first visit, but
Right. Sensitivity was lacking. Yes. On the home front also, definitely there was poor communication. They were avoiding the topic altogether. Right? Yes, absolutely. Right from the beginning, there was poor communication, even at the PHC. Yes. Okay. All right. And then, can we move to the next slide? Now that we have identified all these instances of poor communication, what were the consequences of this? What could have been the consequences of poor communication? Could it be that she was not taking medications because of the poor communication? Is that a possibility, according to you?
poor communication can lead to improper diagnosis. The patient can get very much angry and frustrated because she has to handle work, children, and when female gets sick, then all the family feels that she is a burden. It's very difficult. So health wise, finance wise, emotionally wise, and the children
Right,
also feel a bad environment in the house. So it's also
right,
disturbing.
right, right. Mm-hmm. I can see a lot of responses here in the chat also. Absolutely. Sangeet, next slide. Yeah. So as most of you already know about all these consequences of poor communication, right? First of all, poor symptom control, right? Lack of compliance with the plan of care, because their needs, their concerns, their agendas have not been discussed, have not been addressed. Uh, there's definitely poor adjustment to the illness and the interventions, which can lead to worsening of distress. Like we saw, she was confused, she was scared. The conflicts can escalate. Conflicts might be within the family, it might be between the family and the treating team. Regardless of where they are, conflicts, wherever that they are, can escalate because of poor communication. And this will definitely impact the therapeutic relationship again. And you might have already seen medico-legal problems wherever that you work, because and many a times medico-legal problems stem primarily from poor communication, leading to misperceptions and misunderstandings that happen. Right. Sangeet, next slide. Okay. Right. So basically, now we know that something positive comes out of good communication, and there are negative consequences of poor communication. And there are some people who feel that they're good communicators because they're quite sociable and they like to talk. But is that really enough? Just being able to hold conversations is definitely not good communication, right? So first of all, let's see what is not communication skill before we get into what is communication skill. So conversation is not necessarily adequate communication. A good conversation on general topics, travel, politics, weather, definitely not adequate clinical communication. Trying to convince the patient to follow the agenda that is decided unilaterally by the clinical team is also not good communication. Where we have this how do I put it? This perception that we know best, right? And the patient doesn't know anything. So we will tell you what to do and you are supposed to do it. Now that is again not very good communication. And thirdly, being very, very soothing and gentle without allowing for the patient's participation is also not good communication, right? And as a professional, one very important thing that we all need to understand is communication skills are not inborn. Nobody is born being a very good communicator, especially when it comes to clinical communication. Next slide, please. So then that means there is a good news, right? That we can all learn, we can keep getting better at it because it's a skill that will be learned. It's not an inborn skill. Next slide. So when I say we can all be good communicators, we still are not many times, or we don't really try actively to be better communicators sometimes. Why is that? There's something that stops us. There is also something that stops our patients. It's not that communication is not one-sided, right? Good communication basically means we being good communicators and our patients also being good communicators. So there are barriers basically which may hinder us as professionals. There are also barriers that might hinder our patients. So let us first see the possible barriers that we might have and we might find hindering as professionals. Something that we can all relate to, probably, because we would have all had times when we felt like this, right? So one is definitely that we're too busy to spend time to understand thoughts and feelings of patients. I mean, just especially if you're working in a government setup with a huge caseload, you're definitely not going to have, you're going to feel like I'm so busy, worried in work that where am I going to sit and talk with my patients and understand thoughts and feelings of my patients? Secondly, we might at times be worried about upsetting the patient and handling the reactions. So we'll just try to keep them calm rather than telling them the truth openly. Thirdly, we might just not have the knowledge and the skill, which makes us uncomfortable to touch upon certain topics. So it's basically the discomfort entering into unpracticed areas of interaction. Nothing more than that. Sometimes we're just unable to say, I don't know, when things are not clear to us also. As doctors, it is definitely easier to concentrate on physical concerns. Yeah. And at times we might not even perceive communication as a part of our jobs. We might be worried about being blamed, or we might fear that we'll worsen the situation. And definitely the very practical problem of being unfamiliar with the language or the dialect. So these are the barriers that we face. Now, what are the barriers that our patients might be facing? Next slide. They might perceive the physician as too busy, right? So why should I disturb, or how can I disturb the doctor who's so busy? There might be lack of privacy, especially if it's like a common ward, unfamiliar surroundings. So it's definitely not easy to just open up about our deepest concerns. Again, there's that perception that only physical problems are to be conveyed. So I can tell if my body is in pain. How can I tell my doctor that I'm just scared? Because that's irrelevant, according to me. There is fear of confirmation of bad news, definitely. Some people have an inkling of, they might not know the diagnosis, they might not know the technical term, but they definitely know something is wrong. And they just don't want to get confirmed by somebody who knows it. Yeah. There is also the fear of treatment being denied if they raise questions or doubts on what's happening. There is the fear of losing control over emotions. Mm, Many people are stumped by medical jargon, technical terms, and of course, the hierarchy, the authoritative hierarchy of the hospital environment. No hospital has a very, very accessible doctor who will be like readily available to ask any and every doubt. So you might notice so many of these things were present in my patient also, right? Next slide, please. Okay, and if you're wondering why we're speaking of barriers to communication rather than communication skills themselves, it is important for us to identify these barriers when we see them, because only then can we rectify the barriers first. Because then, if you're not able to do that, however many skills we might learn, we would still not be able to have good clinical communication because the barriers will keep coming. So, hence the barriers before the skills. So, now when we speak about communication skills, we definitely know that communication basically includes acknowledging and understanding the concerns of the patient and the family and responding in the most appropriate manner to bring clarity to the current situation, right? So we hear, we take in information, verbal as well as non-verbal. We are actively, mindfully present and receptive, and then we also respond appropriately. Now, I have here on my slide what we may call as the core principles of good clinical communication. You might notice that it really has very little to do with your language usage and very much to do with being a good human being. And that is the prerequisite, if I may say so. So, first is respect. Treat the patient and the family with respect. That's essential for a healthy relationship, which in turn promotes good communication. Second is empathy. We all know what empathy is, the ability to try and understand another person's feelings, placing yourself in their shoes. It helps to acknowledge the other person's suffering, helps to build a good relationship. Of course, very different from sympathy, which is a sense of pity that the other person may find offensive. Third is trust. Once the patient loses trust in you, you lose the ability to help him. It is as simple as that. Truth is essential for maintaining trust. And lies, for example, if in an effort to conceal the diagnosis, will definitely destroy trust. And lastly, unconditional positive regard, where so we basically need to understand that we have no right to be judgmental, whether the patient is being a so-called good patient or a bad patient, whether they are thankful or grumbling, optimistic or pessimistic. We have to try and consider that person as the most important person for us when we're treating them. And that is what I mean by unconditional positive regard, right? Next slide. Okay. So now let's just have this quick question here. Let us say that I'm taking rounds and there's this patient who tells me that there are so many thoughts and then I can't sleep. Okay, I feel really scared. And then these are the 4 options that I've put here. Which of them, according to you, reflects the core principles? Okay, great. Nice. So that means I've been communicating properly and everybody has understood what I was trying to say. Great. Okay. Next slide, please. Okay. Yes. So, considering that it's quite clear from your answers that you've understood whatever I've spoken until now, let's move a little further into the nitty-gritties of communication. We all know that there are 2 types, right? There is verbal and there is non-verbal. Verbal is basically all that's expressed using language. Non-verbal is all our facial expressions, our body language, gestures, all of that. We all know that communication occurs verbally as well as non-verbally simultaneously. But sometimes we are unaware that non-verbal communication accounts for the bulk of our daily communication processes. Sometimes it can be the sole means of communication in young children, in people who are terminally ill, differently abled, or even emotionally overwhelmed, right? And more importantly, we rely more on non-verbal than verbal communication. Let's say, for example, if I would have to, if I was meeting you all for the first time and I was saying hello, okay, and I said hello, versus I said hello, yeah, you see the difference? When did you feel like my hello was genuine? The first time or the second? The first time I just said hello. The second time I said hello, which was more genuine according to you? Where was I being actually welcoming? The second time, right? Yeah. So, and how did you realize that? Based on my non-verbal communication, not based on my verbal communication. So basically, what I was trying to tell here was whenever there's a discrepancy between our verbal and our non-verbal communication, we trust what is not said. We trust the non-verbal. Yeah. So you trusted my smile and decided that the second time was when I was being welcoming. So it's it's extremely important for us to pay attention to and process not just the verbal, but also all the non-verbal cues that we might get while talking to the patients. And we need to respond to the onset. And we also have to be very mindful about our own non-verbal communication. What are we communicating to our patients, right? For example, let's say a patient is looking gloomy and I ask them, how are you? And they reply with a yes, I'm fine. Okay. Acknowledge that they look down, acknowledge that they look low. Yeah. So let the patient know that you care enough to notice what they did not say. And just like we speak about the patient's nonverbal communication, we are also communicating through our gestures, postures, how we sit, the tone of our speech. So we need to be aware of what messages are we sending to our patients. For example, let's say I'm sitting in front of a patient who's crying. But then when I'm doing that, here I am thinking about, oh, now I'm going to be late for my kid's school function. And I keep looking at the watch discreetly, but I keep looking at the watch. And I'm sitting, but I'm very, very restless and I'm fidgeting, thinking of how I'm getting late. Do you think the patient will notice this? Of course, they'll notice, right? And will that create a block in communication? Of course, it'll create a block in communication. So there are very simple things about our body language which will facilitate communication. Just a genuine smile, an open posture. How often have you seen doctors who are extremely busy typing in their notes when the patient comes in and they begin questioning even before they look up once, right? And I absolutely agree that it's a very practical difficulty that we face given the caseloads. But it hardly takes fraction of a second to just look up and acknowledge that the patient is coming. So simple things like going down to the eye level of a child when you're speaking to in a pediatric setting, when it's the child who is your patient. These are simple things, but they indicate respect and they communicate your genuine interest in being here with the patient. So let's look at some helpful strategies that you can use when you communicate. Sangeet, next slide. Okay. Next one. Oh, sorry, previous slide. Yeah, okay. So first is open-ended questions, right? That's your best friend, okay? So what I mean by open-ended questions, asking, are you in pain today? Versus asking, how are you doing today? There's a difference, right? The first one limits your answers to yes or no. And the second one invites the patient to open up and to express. Open-ended questions will give you more information. It'll let the patient direct the conversation to what they feel is a priority concern for them. That freedom is important for us as well, because otherwise we risk losing out on information that we did not inquire about. So make sure that you always begin with open-ended questions, and then you can narrow down and start asking closed questions based on what they've given you in the open-ended questions. Right? Then there is, of course, summarizing and checking for patient's understanding, where basically we need to find out whether there is a discrepancy between what I intended to communicate and what the patient has perceived. It is also useful to summarize the discussion, because then that will reinforce joint decision making. It will also give the patient a chance to get everything in a nutshell, in case they have felt an overload of information. You could say something very simple, like, for example, I just want to go over what we've been talking about so that I can be sure that we're on the same page. So whenever you are ending a conversation, you could say something like, what questions do you have? Is there something you would like to know more about? And followed by the summary, right? And then definitely arrange for a follow-up. Say that we'll meet again, and in between also, if you think of something that you want to discuss, any questions that come in your mind, please note them down and we can speak about it in our next meeting. So basically you're letting them know that you're here for them. It's not that it's just that's one discussion and then it's done. Thirdly, avoid jargon and avoid information overload. When you're giving information, don't use heavy technical medical terms. Keep it simple, because definitely our goal is that the patient understands what we are saying. Don't give too much information at once, especially when they're in an emotionally overwhelmed state. They might not be able to actually have that much cognitive processing ability at that moment. Definitely encourage them to ask doubts and questions, but at the same time, respect the patient's choice about the extent to which they want to know. It is not compulsory that you tell them everything at one go, especially when they explicitly state that they don't want to talk about something at that time. Most such discussions that you'll have will have a heavy involvement of an emotional component. Make sure that you don't avoid facing them. Be present mindfully. What I mean by mindfully is just in the here and now and without judgment. And listen actively, acknowledge their feelings, let them know that it's okay to feel what they feel, and that it's very natural in the given context. Never invalidate. Let's say, for example, saying something like, you might mean it in a soothing way, but saying something like there's nothing to be afraid of is a very strict no-no. Next is be okay with silences. They help. Sometimes we might get uncomfortable with silences, but learning to be okay with them. Basically, we're letting the patient take their time to process. That's very important, especially when we are communicating, let's say, bad news. So please don't fill the silence with pointless conversation or communication. Why I say pointless is because it's often not heard or received, whatever you're saying, to fill that gap. Right? Or if it is actually heard and received, then basically we have just distracted our patient from actually processing the information or the emotions and from organizing their thoughts before they responded. So let's not interrupt that process. So if your patient is silent and they're taking that time to process, let them take that time. Then there's always this question of hope versus truth. So when we're delivering bad news, we can definitely do it with sensitivity. And we don't have to choose between either hope or truth. We can try and find a balance between the two. So what I mean by that is okay. Instead of saying we can't do anything,
realistic assurance, will that help you? I just
sorry.
Realistic assurance.
Yeah, yes, ma'am. Yeah, absolutely. Yes. So I was actually searching for an example, but so basically maybe saying something like, sorry, there is no treatment available to cure your disease, but we can definitely keep you comfortable with the medicines and regular monitoring, and we are here for you. So you're not taking away hope entirely, but you're also telling the truth that no curative treatment is possible henceforth. So that is what I meant by a balance between hope and truth. So you reassure, but only like ma'am said, realistically reassure the patient. Um, Definitely. Then the next thing is definitely confidentiality, very important, reassuring that whatever sensitive details that the patient might have shared with you, uh, which they might not want to disclose, are being kept confidential. Respecting boundaries, uh, something I've already mentioned partly, that you respect the patient's boundaries about what they want to tell, what they do not want to tell, or what do they want to discuss, what they do not want to discuss. Uh, and of course, further inquiry. So, especially in problem behaviors, okay? For example, my patient is not eating, there is social withdrawal, there is non compliance to medication. Usually, there is a deeper underlying problem, right? Mm. So make sure that you ask, make sure that you always check what is the reason behind that problem behavior rather than just shouting at them for that problem behavior. Yeah. Or just coaxing them to eat or something. Make sure that you're inquiring further. So to sum all these things up, you start with open-ended questions. You let them lead the way. You speak simply. You validate their feelings. You adhere to the core principles. And you end it by summarizing. And then you make sure that the doubts are answered. You ensure a follow. Right? I hope that's clear. Does anyone have any questions? I think I saw a question in the chat.
Yes, there is one. They've asked if they still ask that if they say there, what if the patient stresses on there is no curative treatment?
That's quite possible. And see, we can't decide what the patient is going to take in and what the patient is not going to take in. And that is where your acknowledging and validating emotions will come in. And this is also something that we are going to see in the next session about breaking the bad news, where they might have selective uh, attention. Like they pay selective attention to either only the good part or only the bad part. And that is where we need to um, really be there with the patient, acknowledge what they're going through, let them process their emotions, and then reiterate what we were seeing. So it's not an instantaneous thing, like it's not. So this example which I gave you was, it's not going to be just that one sentence and you're done. It's going to take time. It's going to take you repeatedly telling them about what is possible, what is not possible. And definitely it's not going to be easy or simple. And I think with the next session it'll be a little more clear what you're supposed to do practically when it comes to patients, like hanging on to certain parts of information. Anyone else? Any other questions?
That's it. They've just answered for responding. As you said, only it will be more helpful with the next session. And some of the answers you have given also, no? Like sometimes being quiet is for them, giving the
Yeah.
time for them to process. See,
Right.
if you give the time, they may process. Oh, the option is not there. So then what next?
Yeah.
So in two ways, both will be there.
Right. Yes. Okay. So next slide. Yeah. So we've already seen what we are supposed to do. Let's also see what not to do, because that's also equally important. Most importantly, never moralize or philosophize. Okay, we are not, however much we empathize with our patients, we are not in their place right now where they're actually facing mortality, right? So let's not moralize, let's not philosophize, let's not say stuff like, how can you wish to end this life? This life is a gift by God, things like that. Okay. Because that is actually an insensitive thing to say to a person who's facing that much distress, where they feel like they don't want to live anymore. Avoid comparisons. Okay, you might mean it in a very, you might mean to motivate the person or whatever, but that doesn't help. So when I say avoid comparison, what I mean is, let's say, for example, telling them that, oh, you see that patient is younger than you, and he doesn't cry on such silly things, and there are so many others in a worse condition. No, don't say that. Don't make meaningless statements which can stop further communication. By meaningless statements, I mean things like, there is nothing to be afraid of and stuff, because we all know that there is a lot to be afraid of. So let's not say that. Jargon, which I've already mentioned, that don't use jargons. Um, I mean, if you're telling your patient that the carcinoma is radiosensitive and it increases chances of remission, the patient has not understood anything, whatever that you've spoken so far. So avoid jargon, uh, avoid false reassurance, saying that no, everything will be right. And you see, you'll just walk out of the hospital door quite fine, and don't do that. Don't give false reassurances. Don't make assumptions. Always ask why. Always ask what made them ask a question, what made them say something. Don't be condescending. Don't have that attitude of, do you know more than the doctor? Don't force your beliefs on the patient, religious, spiritual beliefs, whatever. Um, don't have a sympathetic attitude of, oh, poor you, I pity you. Never use inappropriate humor, where sometimes people people can be insensitive in their use of humor. I mean, they might be trying to just lighten the mood, but in such serious situations, let's not use inappropriate humor. Uh, let's also not be thoughtlessly. When I say false reassurance, there's this other part of it where thoughtless honesty is also not something we need to be having. So it's not just about what you say, but also how and when you say it. So you tell the truth, but how you tell the truth and when you say it and how you say it, that's what is going to matter the most. And definitely avoid lies, because they'll break the trust. And like I already mentioned, once the patient has lost trust, you lose the ability to help that patient. All right, next slide. So let's just put things in a sequence so that it's easier for us to put into practice. So the steps, if you go to say, for effective communication, firstly, of course, you build a relationship where you take your time and privacy, and you set the scene, and you convey empathy with your expression. You make sure that your verbal, non-verbal communication is such that there is a rapport built, basically. That is what I mean by building a relationship. Secondly, you open the discussion when you're communicating, and you acknowledge feelings like pain or loss. Acknowledgement of suffering will make the patient feel that they are understood, unlike dismissal of these emotions. So acknowledge their feelings, listen actively, and listening actively will definitely involve your eye contact, appropriate facial expressions, body language where you lean a little forward, verbal responses where you make sure that they know that you're listening. So saying things like, "Oh yes, I see," asking questions, um, encouraging the patient by repeating the last few words or paraphrasing. So listen to what is said and also to what is not said, specifically their nonverbal, like the body language and the facial expressions, which might indicate suffering. So all that will happen in your opening of the discussion. After that, you'll move on to gathering information, where you'll basically explore and find the patient's level of understanding and insight. What do they know? How much do they want to know? Use open questions or statements which will invite responses. So let's say, for example, what do you think might be the problem? What worries you most? That must have come as a shock to you. So let them take it further from there, and you listen. And then you understand the patient's perspective. So based on your open-ended questions, they'll start answering, and that is how you'll understand how do they feel about it all. Do they have any questions? And here is when you'll have to be prepared for an emotional reaction: sobbing, anger, silence, despair, whatever that the patient throws at you. It may be necessary to facilitate sharing at times. So you might have to actually prompt, you might have to say that, could you tell me your thoughts? Could you tell me how you're feeling? And only then you reach the sharing of information from your side, where the patient will decide the agenda for further discussion. And so basically, in other words, what the patient considers important must be discussed at that stage. And if they want to postpone discussion about further treatment, within a reasonable time frame, we can do that, because they might not be in the right frame of mind to actually talk about options. The patient has a right to know everything, but they don't have a duty to know everything. So make sure that you confirm what they really want to know and then share information. And if they say stop, or if they say that no, I don't want to talk about this right now, like I said, given a reasonable time frame, we can do that. Use common conversational language when you are sharing information, and check understanding at every stage. After that, you'll reach an agreement on problems and plans, right? So once you know how they are feeling or what they know about it, and you've shared information from your end, and then you summarize the problems that you've spoken about, you suggest a course of action, or you give them choices. You answer any questions they might have. And you arrive at a course of action which is acceptable to the patient, but at the same time, making it clear that it's not an ironclad contract and the plans are negotiable. It's not that, okay, we had decided this last week, so this is what we'll stick with. No. And the patient should know that this is not how it's going to be. They can change their mind at some point if they feel differently about it. And definitely, lastly, close the discussion very sensitively. Avoid abruptness. Review and summarize discussion before finishing, and of course, leave the door open to talking again. Right? Any questions? I think somebody has put up a
There was
question.
one question in the chat, Mukta. What if the patient went on denial anger and in search of hope, chose alternative treatments like native medicine? Does that mean poor communication?
See, there could be multiple reasons of why people do that. It's not only about, I mean, poor communication can definitely lead to something like that. But that doesn't mean that sometimes, in spite of our best attempts to communicate, patients will still choose to do something like this. And
See,
yeah, ma'am.
that is patient's autonomy also, isn't it? See,
Exactly.
we have to communicate. Final decision is patience. So in that question, no, two things are there. One is autonomy, and then next is we need not see. We are supposed to give the choices, and all the choices we will give. The right, wrong, and what they want to choose is their decision. So, like as you said, as Mukta said, no, like you give everything, they may still choose it. You don't do something properly, they can still choose it. So, non-judgmental is what is important there. And I think through these 7 steps itself, I remember Mukta mentioned that in spite of all this, this denial, there are some phases. Most
Yeah.
of the patients will go through denial, and then only by them contemplating and understanding, they will have to come over denial. But we can be helpful in them to understand. But denial has to be overcome by the patient themselves. We cannot overcome their denial.
Right.
Isn't it? So these are these are all a little bit of things which by seeing patients and experience you will know. And not only patient, all of us will have this. Denial is not something only related to medicine or oncology. Even some facts and figures each one of us may have. So these are all emotions, different types of emotions which happens situational they are. So those are the important things.
Right.
Has that answered, Dr. I think Dr. Abdul? Yes, he has replied. Go ahead, Abdul.
Also, I think what is most important is that in such situations, first of all, like I already mentioned, we are very clear that we are not going to take a high stand here where we say that I know best and you will do what I'm telling you. And then, so like ma'am also said, we give them all the options and we give them all the pros and cons and everything. And then the patient chooses. And let's say a patient chooses something like this and they go uh, try an alternative and then it doesn't work out and they come back. And then how you react or how you respond in that situation is actually going to matter more. So rather than being sarcastic, rather than that is where your non-judgmental uh, acceptance, unconditional acceptance will come in, where you'll still have empathy for the patient if he comes back, when he comes back.
Mukta, one more thing I just want to tell. We do have a case presentation also.
Oh, okay. Yeah, yes. Just 2 minutes and I'll finish. Okay, so I'm done with the presentation. Actually, I just want to ask if anyone is wondering what happened to my patient, S, whom we visited at the start of the session, and what I did when I met her. So I'll just quickly tell you what happened, and then we can start with the case presentation. I did exactly this, the 7 steps that you see here. So I built a rapport. I introduced myself. I told her that I had come to speak to her about her illness and to know how she's doing. So the moment she realized I was not here with an agenda, but with genuine concern about how she's coping, she opened up. The first thing this lady told me was she had heard the word kidney for the first time in her life. She had no clue what it did or what it was. Basically, when she was told her kidney is not functioning, it sounded very alien to her. It had no meaning. However, she sensed the seriousness of the atmosphere. She came home and, with the help of her 11-year-old son, she Googled kidney. Okay. And so she understood a little bit about what it was. Now, people who could communicate the right information were not doing that. But there was no shortage of people with baseless information who had no forms of questions about is this true or how will it impact her. So she heard all kinds of stories about how this means that she's going to die, all sorts of scary and tragic stories filled with negativity and despair. And she did her best not to listen to them. Okay. And in an attempt to do that, she overcompensated by denying the seriousness of what had happened. She was tired of the 30 plus tablets that she had to swallow every day. She had tons of questions and no one to answer. So we started right at the beginning. We started with what a kidney is, what it does. Most importantly, that there are 2 of those and we can function with one. Because the major problem with her was she felt she was asking her parents to sacrifice their lives by asking them to give her their kidney. She cried, she let things out, and she asked all her questions. She expressed her needs of how uncertainty brings fear, how anxious and worried she is for her son who has grown up too soon in all this ordeal, and how if she were to know what was going to happen, what the doctors were doing, she would be much better prepared. Yeah, she knew what she wanted, clear communication. knowing what had happened to her, knowing what was being done to her, and knowing what could happen to her. She had very simple needs. At the end of the first session, I did tell her that she was free to get in touch if at all she had any doubts at a later point as well. After the first consultation, she became much more cheerful. She started expressing more openly to everybody. Communication at home with her husband improved. We began meeting her son periodically as well. That eased a big load off her shoulders because she had specifically requested for that. She began actively working towards treatment. She took the initiative to tell her family about this, about the transplant, the related issues, which she had not done until then because she didn't know what to tell them. I met her family along with her and her husband. And we did speak to them and we discussed what treatment options were available. Her father is currently, he has come forward as a donor after discussions within the family. She is currently taking her medications and taking them with courage and hope in her heart. S is fine. Yeah, so that's it from my end, and we can start the case discussion.
Yes, they can go ahead with the case discussion as well.
So today's case is presented by Dr. Himanshu. I welcome, sir. Over to you, sir.
Hello, am I audible?
Yes, sir, you are audible.
You're audible, but Sangeet, we can't see the case presentation. Is that, can I, because are you sharing or?
Yes, ma'am. You can't see? Just let me reshare
Yeah,
one.
it's visible to me, ma'am.
Okay.
So, good evening, everyone. Today I am going to present a case scenario on introduction to communication. Next slide, please. So, this is a case of a patient named John Smith with who is diagnosed with advanced prostatic cancer. His age is 72 years. Next, please. So, presenting complaints is like John, the patient John, who is a retired gentleman. He presented with advanced prostatic cancer with severe pain in the pelvic region, most probably due to bone metastasis. Then difficulty in urination, most probably from the tumor mass encroaching the urethra and all. Then fatigue and profound anxiety. Next, please. So when we go into the history of illness, John was diagnosed with prostatic cancer about 5 years ago. Despite undergoing surgery, chemotherapy, and radiotherapy combined, his cancer has progressed to a very advanced stage. He has also developed changing, ma'am.
Hi, ma'am.
Because I am not able to see, so that's why I'm asking.
Sorry, ma'am. My Wi-Fi just switched off. That's why. I'll reshare it once. Is it visible now, ma'am? Dr. Himanshu, is it visible?
Yeah, it's visible to me. Even before it was visible to me. but I don't know whether it is visible to everyone or not.
Can anybody confirm if it's visible to
Yes,
everyone?
madam. Yes, madam. Visible. Visible.
Yes.
Visible.
When we go into the history of present illness, John was diagnosed having prostatic cancer about 5 years ago. He underwent surgery, chemotherapy, and radiation therapy, but his cancer has progressed to an advanced stage. He has developed metastasis to the bone, which is causing debilitating pain and functional impairment. Next, please. Upon examination, we see that John is appearing very fatigued and he is in severe significant distress. He demonstrates a limited mobility due to pain as he is having severe pain and exhibits signs of urinary obstruction. Physical examinations reveal there is pallor, cachexia, tenderness over the lumbar spine and pelvic bones. Next, please. Next slide, please. Previous one. Treatment. Yeah. As he is having very different aspects of the disease, accordingly, the treatment is divided as for pain management, John is prescribed opioid analgesic, including morphine, along with adjuvant medications such as antidepressant, gabapentin for neuropathic pain. Urinary symptom management included alpha blockers and anticholinergic medications to alleviate urinary symptoms and improve urinary flow. John received palliative radiation therapy to target painful bone metastasis to elevate localized pain. Psychosocial support, John is referred to a palliative care psychologist for supportive counseling and coping strategies to address his anxiety and emotional distress. Next, please. Psychosocial aspect. Here, the importance of communication is there. John's diagnosis of advanced prostate cancer has significantly impacted his emotional well-being and quality of life. He is very anxious and very fearful about his prognosis. He is very worried about burdening his family, both financially and socially. He struggles with existential concern related to mortality and loss of independence. John's wife Mary is also experiences emotional distress and caregiver burden as she navigates the challenges of supporting her husband through his illness. Because Mary is the only family member John has, so she is also very much concerned about for smooth management of the disease and the caregiving process. Next, please. As medications, the treatment modalities which I discussed for if we go to the appropriate, exact drugs for pain, John was given morphine sulfate, both immediate and extended release for pain management, and antidepressant like gabapentin for neuropathic pain, tamsulosin for urinary symptom relief, and oxybutynin for overactive bladder symptoms. Next, please. So the main concern here is the pain management as well as emotional distress. John experiences profound anxiety and existential distress related to his illness, prognosis, and end of life concern. And also the support, the caregiver support, who is Mary and John's wife, expresses concern about managing his care at home and coping with her own emotional well-being as his primary caregiver. Next, please. So if we can summarize the case as John Smith, who is 72 years old man with advanced prostatic cancer, presents with debilitating pain, urinary symptom, and profound emotional stress. His palliative care interventions included pain management, symptom control, psychosocial support, caregiver assistance, which are initiated to optimize John's comfort and quality of life. Effective communication strategies here included emphasizing empathy, like ma'am earlier said, the putting any other person's shoes, so as to know their pain and putting putting ourselves in their position. So uh, by that we can emphasize empathy and shared decision making. In every decision making, like all the alternatives are given, and decision should be taken by the family members and the patient concerned. And holistic care, which are integral to addressing John's concern, enhancing his coping mechanism, prompting dignity and autonomy throughout his palliative care journey. Next, please. So here, important points to discussion are the importance of good communication, which is, in my opinion, comprises of these things, like ensuring comfort. When we introduce self with name and role, the patient, the rapport building is quite good. And we should also address the patient by name, and the caregiver, we should also identify by person the caregiver. Then assess emotional state, how the person is feeling. Like ma'am said, with open-ended question, like we should not go for leading question which answers yes or no, not closed-ended. Then assess emotion, listen to concern. We should always encourage to ask patients and their caregiver what their concerns are, and we should always respect and meticulously respond those concerns. Then reassurance, like the patient and caregiver always go for, say, this is the end and there is nowhere to go around. So these type of delusions, which we should remove that by giving reassurance. And assess the needs for information, like the patient and caregiver should know the state of the disease, the prognosis, the treatment modalities, and all the alternatives for palliative care. So that information should be provided. Then deliver information with empathy, explore emotion and provide support. We should explore, to know how they are feeling, that is explore emotions, and accordingly we should provide support. So that is all. I think it can be discussed now. Thank you.
Thank you. Thank you for the presentation and taking us through the case. Mukta, you can go ahead and the rest also, like what do you feel, how to address those concerns and how to solve the issues? Okay, anyone can unmute and speak or type also. There is one question in the chat which I will tell once this discussion goes on. Someone was going to speak. Please go ahead.
Hello, ma'am, Dr. Himanshu here. Ma'am,
yes,
I've got a question. How to assess emotion? Is there a scale? I'm not aware about any scale, but to know the emotions, we should inquire them
No.
like
Like that question, the question in the chat box, you need not answer. We'll ask Mukta about it. And so
okay,
I
ma'am.
was, no, I was just asking regarding the case. If you have any queries with the case and then case management, the questions in the chat box, we will discuss with Mukta. You go ahead, Mukta, first.
Hello. Yes. So I think a lot of these questions are, things which would have been addressed probably in the psychosocial aspects of palliative care also, if you've already had the session. So especially when you think of the uncertainty and the anxiety that your patient is facing. Do you have any particular question about that, sir?
Psychosocial, we will have a separate session later
Yeah.
on, Mukta. We have not yet
Yeah.
had that.
Oh, okay. No, because especially because he was mentioning about the uncertainty and the anxiety that that the patient is facing, and that seemed to him a priority. So when it comes to communication, is there any specific issue that you're facing with this patient? So, Dr. Himanshu?
Hello. Yes, ma'am.
Yeah. Yeah, so I wanted to know whether you are having any particular difficulty when it comes to communicating with the patient.
Madam, it's actually how to explore their concern. I mean, usually these type of patients don't open up very quickly. So, I mean, it will take some time, no doubt, but
Right. You also mentioned that the rapport is quite, you have a rapport with the patient.
Yeah, rapport building is very important, but still then we might face challenges in that.
So, see, first of all, it's the most important thing is for your patient to know that they can ask you anything and everything. So it need not be only about, and sometimes if you feel that the patient is not asking, but they do have doubts, you might have to coax a little bit. So that is also something that we'll see in the next session, where you might have to ask specifically, how are you feeling? You might have to ask specifically, do you have any doubts about, or have you understood what the doctor or anybody from the treating team has told you?
Yes.
So yeah, so that is something that you might have to proactively do from your side if the patient is not telling you.
One more thing, what you can generally ask is, what is that's most bothering them? See, we may think something else. See, for example, generally you may think financial, but that may not be the thing which is bothering them. So what is that's bothering them the most is one question which may help them to open up. And the more, like, see, one session, if you're going to expect, again, each person or patient is different. So one session, they may not open up. So you may need few more sessions. And then if they still don't open up, you may need the help of the psychologist. So those are the things step by step, like few sessions. That's why all through, and then this the 7th step. No, first you have to gain rapport, then explain. You have to tell them like not using jargon, not like a medical person. What we understand, they may not. So exactly all these what you have heard today, no? That is how you have to do. First, you have to that introduction, body language, everything, and then you slowly explain. And then every time you explain, you give them some time and ask them to repeat in simple words. So then itself you will know whether they have understood or not. For example, you have said something and they totally, when you ask them to tell it in their own words, they may not be able to. So that shows you may have to do it again. So that is how you will have to do and get the information from them and then give time and then go back and forth with them too. So that is one. And then one more question I had when you said about the case, is that only the husband, wife? No other family they have? Because that was not there in your case information. And no siblings, no children, no issues, no siblings for either of them. Is that how it is, or can you add more information to that, Dr. Himanshu? Dr. Himanshu, can you hear us?
Hello. Yes, ma'am.
So what I was
Hello.
asking is it just the husband, wife only? There's no other
Yeah.
no children,
His wife
no.
is the only family
Huh?
he had. His wife was the only family he had.
So they don't have children, and neither he has brothers, sisters, nor she has brothers, sisters.
No, ma'am.
What is it? Is it no for all my questions, or you can you? Okay, I don't know whether he has got my question. Mukta, there were two questions in the chat. Is there any scale to assess emotions? And how do we reassure the caregiver?
Yeah. Okay. So, the first one, yes, there are scales. There are scales which can be used. But I would really suggest that. I mean, the scales, of course, you will also get to know if you are having a psychosocial aspects session later. You might be told about the scales, but it's not, I mean, I would still insist that you don't rely completely only on scales to assess emotions. Emotions are best assessed by observing your patient. That is how you'll know. So, because scales are easily forged, they can easily lie on scales. So scales are definitely a helpful tool. And there are a lot of scales where there are face scales which can be used for a general idea. There are specific
Distress
scales for specific
thermometer.
emotions. There is the distress thermometer. If you are suspecting, let us say, a clinical emotional concern like depression, then there are specific scales for that. And so there are a lot of scales available. But on a preliminary level, firstly, you should be able to identify the intensity. You might not be able to give a clear-cut answer to, okay, this much percentage and stuff, but just to know how intense that emotion is and what is that emotion in the first place. Is it anger? Is it something else? Is it sadness? Is it guilt? Is it hopelessness? So that is something that you'll know by once you start talking, once you start letting them talk, and when you observe. I hope I have answered the question.
Yes,
But if
Mukta.
they
See,
still
same.
want, no, if they still want
Yes,
names of scales, I can definitely share, and then maybe Sangeet can pass it on.
Yes, just as I was also about to tell, like you have the distress thermometer. You can share some scales, Mukta, if you
Yes.
could.
Yes, sure.
Like you have the distress thermometer and you have the HADS score scale also. There's which assesses. depression, sleeplessness, everything is there. So there are multiple skills, but always well said, Mukta. The clinical thing is also to be taken hand in hand always. Yes, these skills are tools to help us. They are the tools to help us. And the distress thermometer is a simple one which is generally used. So that can be done, and seeing the patient and going, finding in which emotion they are and going little by little. And then the psychologist, in the psychology session also, you will have more information. And then reassuring the primary caregiver is exactly the same. See, what does palliative care definition say? Again, maybe you all will be thinking, I'm telling the same thing on every session. Yes, true, but you give equal importance to the patient and the caregiver. As you would explain, see, sometimes you may not be able to explain or have a discussion with both of them in a same room. So those situations, you do the same in 2 sessions, one for the patient, one for the caregiver. Or if they are in a situation where they are open, no, so then you can do with both. So that if you could do having both of them, that will be the best. It is like one same thing heard for both, or 2 aspects of it. The caregiver also, you have to say from their point of view, what is important, and from patient point. Simple example I'll give: food. The caregiver will always want to keep giving food, because food is considered as one form of love and affection. But if it is a patient who cannot eat at all, so then you have to tell what is the patient's condition to the caregiver, and then give a solution also. Okay, from patient's point of view, patient can't eat too much, and from your point of view, you want to. So small frequent meals is one simple example which we say. So they may not be able to eat as a normal adult would do, like 2 meals or 3 meals in a day. So, but instead of that, you give these options. Every 2 hours, you give something in small quantity. So in that way, you are looking after the patient and the caregiver. So here, the question in the chat box was reassuring caregiver. No? So you have to explain things, understand, ask what is their concern again. So everything, no. So finding out. That's why don't assume. So all through today, no, all what you have heard, you have to put everything into practice. Like listen, make sure that you listen, you speak, make sure that they understand, and then that making sure that understand, you're asking them to speak, and then give information in small chunks, and then finally summarize, so that you make sure that they've understood what you wanted to convey. Have I answered what your queries were? If someone still has anything, okay, thank you. If somebody wants to ask anything, please go ahead and ask. Otherwise, thank you, Mukta, for taking us through this session very well. And as you said, the rest of the queries will be answered in the next session also. If there are no more queries, I will hand it over to Sangeet.
Thank you, ma'am. Thank you, Ms. Mukta, for the wonderful presentation. Thank you, Radha ma'am, for facilitating the session. And thank you, Dr. Himanshu, for presenting the case presentation. Thank you all for participating. Let's see you in the next session. Bye.
Thank you.